Unit 2 Family Therapy Meaning, Scope, and Applications. 1. Introduction. In recent years, there have been changes about the notions of family and family life. In many developed as well as developing countries, for example, approximately over 40% of new marriages end in divorce. Many people choose not to marry, and there are increasing variations, such as single-parent families and homosexual families. In addition, there is greater diversity in people's expectations, such that men no longer are expected to be the sole or main breadwinners, and there are expectations about greater sharing of domestic roles, such as childcare. Arguably, some of these changes are less extensive than might be assumed. For example, women, even if they work outside the home, tend to take on the bulk of domestic duties as well. It is easy to assume that in some ways the family is in crisis, which is also seen as a fundamental threat to the stability of society. Some of the traditional values, emphasizing domestic duties, passivity, and primary responsibility for providing care of children and aging relatives, have not been in the best interests of women. What we take to be the family and family life is influenced by the ideologies and discourses inherent in society. An analysis at the level of society and culture suggests that family life is shaped by dominant ideologies or discourses about what family life should be like. For example, the roles of men and women in families and other living arrangements have changed significantly in the last 40 to 50 years. If we accept that many people make such choices, the question remains of how people go about constructing their own varieties of family life. How do they decide how normal, as opposed to how deviant, they will be? Accounts from families and therapists can be seen to pertain to two aspects of family life, which at first sight might appear contradictory. On the one hand, people do appear to make autonomous decisions about their lives. On the other hand, family life can be seen to be characterized by repetitive, predictable patterns of actions. Families are inevitably faced with various tasks, difficulties, and problems that they have to find ways of managing. These tasks alter as they proceed through their developmental cycle. Objectives. After studying this unit, you will be able to understand the basic concepts related to family therapy, identify the various approaches to family therapy, analyze the indications, applications, and contraindications for family therapy, and assess families who are resistant, not amenable to family therapy. 2.2 Family Functions. The main functions performed by the family are as follows. 1. Socialization of children. 2. Economic cooperation and division of labor. 3. Care, supervision, monitoring, and interaction. 4. Legitimizing sexual relations. 5. Reproduction. 6. Provision of status like social familial attributes, for example, SES location. Status can be I ascribed, for example, birth order, or E achieved means based on an individual's effort. 7. Affection, emotional support, and companionship. SA 2.2.1 Functions and Characteristics of Healthy Families. A functional family is characterized by transactions that serve to meet the needs of the individuals in the family and the family unit as a whole. Functional families are characterized by structures that are adaptable and well-defined. The characteristics of a healthy family include the following: clearly identified hierarchy, well-defined parental roles, flexibility and adaptability, meaning healthy families can respond to situational and maturational crises, consistent, clear rules and expectations, consistent affection, consistent limit setting, open communication, bidirectional, and increased degree of support, nurturance, and acceptance of family members. 2.2.2 Dysfunctional families. A dysfunctional family system occurs when a stressor overloads the family's adaptive and coping mechanisms such that family members' needs are not adequately met. 2.23 Characteristics of dysfunctional families. The characteristics of dysfunctional families are stated below: rigidity or lack of flexibility, lack of individuation, like enmeshment or loss of autonomy, extreme detachment, scapegoating, meaning a family member, often a child, is the object of displaced conflict or criticism, triangulation, meaning detouring conflict between two people by involving a third person, thereby stabilizing the relationship between the original pair, faulty problem-solving skills, conflict avoidance, inconsistent application of affection or discipline, low levels of support, nurturance, or acceptance, and increased degree of expressed hostility towards each other or other family members. 2.3. The concept of family therapy. Family has long been recognized as a fundamental unit of social organization in the lives of human beings. The significance of family factors in the maintenance as well as the treatment of mental disorders has been established by many studies. The term family therapy was coined by the American psychiatrist Nathan Ackerman in the 1950s. It covers a variety of approaches and is practiced by a variety of professionals. The key features of family therapy are as follows. Family therapy is a branch of psychotherapy that works with families and couples in intimate relationships. The main feature of family therapy is the treatment of more than one family member in the same therapeutic session. Family therapy is a form of psychotherapy that involves all the members of a nuclear or extended family. Marriage and family counseling or therapy focuses on the well-being of primary relationships and systems. In family therapy, the family system as a whole, not just one family member identified as having the problem, is treated. Family therapy deals with problems involving family structure and family interaction patterns. This approach regards the family as a whole as the unit of treatment and emphasizes such factors as relationships and communication patterns rather than traits or symptoms in individual members. Family therapy is becoming an increasingly common of treatment as changes in society are reflected in family structures. It has led to two further developments. One, couples therapy, which treats relationship problems between marriage partners or gay couples. Two, the extension of family therapy to religious communities or other groups that resemble families. 2.4. Difference between psychotherapy and counseling. The terms counseling and therapy are commonly used interchangeably in describing what the marriage and family therapist actually does. The term counseling is used when a strong component of the process is educational, as when parents learn new ways of handling children's behaviors or when spouses learn better ways of communicating. Counseling is probably the most appropriate term to describe the process when the couple or family is basically healthy, yet seeks enrichment of their quality of life together. Therapy may be more appropriate when there is a great deal of emotional stress or pain in the relationship or system. Professionals often prefer the term therapist to counselor as a label because it includes educational functions as well as treatment functions. Blocker, 1966, distinguishes between counseling and psychotherapy by pointing out that the goals of counseling are ordinarily developmental, educative, preventive, while the goals of psychotherapy are generally remediative, adjustive, therapeutic. He describes 5 basic assumptions about clients and counselors that differentiate the two. 1. Counseling clients are not considered to be mentally ill, but are viewed as being capable of choosing goals, making decisions, and generally assuming responsibility for their own behavior and future development. 2. Counseling focuses on the present and future. 3. The client is a client, not a patient. 4. The counselor is not an authority figure, but is essentially a teacher and partner of the client as they move toward mutually defined goals. 5. The counselor is not morally neutral, but has values, feelings, and standards of her or his own. Although the counselor does not necessarily impose these on clients, they do not attempt to hide them either. The counselor focuses on changing behavior, not just creating insight. Similarities between counseling and psychotherapy. Counseling and psychotherapy are similar in many procedures adopted and concepts used. Some of them are given below. The nature of seating arrangements and directions during the process of conducting sessions are more or less the same. In both therapy and counseling, a special relationship is built, and both value clients. Psychotherapists and counselors use the same theoretical models. Counseling skills are used by those practicing psychotherapy and counseling. Both therapy and counseling have the same ethical and professional boundaries, such as confidentiality, time limits, payments, and ethical issues. 2.5 History of Family Therapy. Family therapy has several roots. The main roots are as follows. 1. Child guidance centers. Child guidance centers brought parents into treatment began in the 1930s through Nathan Ackerman, who is considered the grandfather of family therapy. 2. General systems theory. Biologist Bertalanffy studied components of a self-regulating total system in continuous change, seeking a steady state during the 1940s. 3. Group therapy. Group therapy used small group processes for therapy after World War II. 4. Psychoanalysis. Freud acknowledged the role of family relationships in personality development after World War II. 5. Schizophrenic studies. Bateson's work on double-bind interactions during the 1950s. Family therapists emerged in the 1950s and 1960s. Early psychotherapy approaches focused on individual therapy and the patient-therapist relationship in treating psychological disorders. Although theorists believed families influence personality, theories suggested the most important factors governing human behavior were internal and subjective. Treatment, therefore, focused on neurotic conflicts and destructive interactions in the family of origin. Patients were treated separately from their families. Family therapists hypothesized that psychological problems were developed and maintained in the family context. Personality was viewed as related to reciprocal interactional patterns with others. Psychological dysfunction was explained in terms of circular, recursive interpersonal events. 2.6 cycle. The family life cycle emphasizes how development and change in families follow certain common patterns, shaped by the shifting patterns of internal and external demands in any given society. Families may at times be faced with massive demands for change and adaptation. This may be the result of changes in family composition, such as the birth of a child, a divorce or remarriage, a death, or changes in autonomy within the family, e.g., children becoming adolescents, a woman returning to work after childrearing, retirement, etc. It was argued that problems frequently emerge during life cycle transitions due to their inherent demands and stresses. However, less attention was given to the possible positive effects of external inputs, such as the arrival of a child uniting a couple or a bereavement drawing family members closer together. The external and internal demands for change are continuous, but become critical at transitional points in the family's life. Family life cycle stages, transitions, independence, coupling or marriage, parenting, babies through adolescence, launching adult children, retirement or senior years. 2.7 Indications and contraindications for family therapy. Indications for family therapy. Common child psychiatric disorders, child abuse, eating disorders, especially anorexia nervosa, depression, schizophrenia, marital and family distress, families with problems across generational boundaries, families scapegoating, anger, or undermining the treatment of a member in individual therapy. Contraindications for family therapy. Members who cannot participate in treatment sessions because of physical illness or similar limitations. Families in which one or both parents are psychotic. Members with very rigid personality structures. Families that are unstable or on the verge of breakup. Family violence and sexual abuse. In cases of family violence or sexual abuse, family therapy is initially contraindicated since the child is unlikely to express feelings in the presence of the perpetrator, who is a family member. If the perpetrator is an outsider, the presence of both parents provides support and encouragement to the child. A multimodal approach is indicated in these cases, including individual or group work for children or parents, followed by a family approach later when the rehabilitation of the child and parents is contemplated. Families where both parents suffer from chronic, unremitting, or residual psychotic disorders may not be amenable to therapy. 2.8 Family therapy as a process. Family therapy tends to focus on resolving specific problems. In family therapy sessions, all members of the family and the therapist are present at most sessions. The therapists seek to analyze the process of family interaction and communication as a whole. They do not take sides with specific members. Therapists make occasional comments or remarks intended to help family members become more conscious of patterns or structures previously taken for granted. Family therapists working here is the corrected version of your. Therapists make occasional comments or remarks intended to help family members become more aware of patterns or structures previously taken for granted. Family therapists working as a team model new behaviors for the family through their interactions with each other during sessions. Family therapy is based on family systems theory, which views the family as a living organism that is more than the sum of its individual members. Family therapy uses systems theory to evaluate family members in terms of their positions or roles within the system as a whole. Problems are addressed by changing the way the system functions rather than attempting to fix a specific member. Family systems theory is grounded in several major concepts or assumptions. Preparation for family therapy. In some cases, the family may be referred to a family therapy specialist by their pediatrician or another primary care physician. Family therapists may include psychiatrists, social workers, clinical psychologists, or other professionals. Therapists typically evaluate a family for treatment by scheduling a series of interviews with immediate family members, including young children and significant or symptomatic members of the extended family. This process allows the therapist to understand how each member of the family perceives the problem and to form initial impressions of the family's functioning. Family therapists usually look for the level and types of emotions expressed, patterns of dominance and submission, roles played by family members, communication styles, locations of emotional triangles. They also observe whether these patterns are rigid or relatively flexible. Preparation often includes creating a genogram, a diagram that depicts significant persons and events in the family's history. A genogram is a key tool for assessing families, providing a visual representation of a family's composition, structure, member characteristics, and relationships. It helps uncover intergenerational patterns of behavior, marriage choices, family alliances and conflicts, the existence of family secrets, and other information that sheds light on the family's current situation. #2 Assessment in family therapy. Family trees or genograms and timelines are useful diagnostic tools in family therapy. Let us now discuss various techniques for assessment in family therapy. 2.10.1 Family Tree. A family tree is also known as a pedigree or ancestor chart. In this, family relationships are represented in a tree structure. Generally, the oldest generation is presented at the top and the youngest generation at the bottom. For example, if we are making a family tree of a 5-year-old boy, his grandparents are presented at the top, followed by his parents and other children of his grandparents, with him and his siblings at the bottom. 2 Timelines. Timelines can be used to ensure family trees remain useful and uncluttered, and to show changes in occupation, location, life course, illness, and other predictable and unpredictable life events. Therapists and clients are invited to identify a time in family life that is a snapshot of family processes. This should be at a significant point, for example, at the point of referral for professional help or at a life cycle transition such as leaving home, the death of a parent or spouse, etc. The family tree is drawn showing, where possible, up to 3 or 4 generations. Themes to look for and explore may include separation, loss, conflict, closeness, communication, power, and family beliefs, myths, and legends. Explanations and responses to crises and life changes can also be described. The therapist develops a working hypothesis regarding family structure based on observations of family interactions. Problems are defined in ways that make the problems amenable to change. Assessment information is gathered from 5 areas. 1. The family structure, including its preferred transactional patterns and the alternative patterns available. 2. The system's flexibility, reflecting its capacity for elaboration and restructuring. 3. The family system's resonance, reflecting its sensitivity to individual members' input. High sensitivity reflects an enmeshed system. Low sensitivity reflects a disengaged system. 4. The family's developmental stage, assessing its performance of tasks appropriate to that stage. 5. The family life context, including the sources of stress and support. 2.10.3 Genogram. The genogram is a map of family processes. It can be described as a graphic representation of families that charts the interactional processes over 3 generations. With its lines, boxes, circles, and symbols, the genogram records important facts, life-changing events, and complex relationships within a family system. These deceptively simple explanations capture the essence of a complex clinical and consulting instrument that depicts nuances of description and relationship, which may be lost in larger narratives or omitted in an overly intense focus upon the self. The construction of a genogram is an interpersonal event in which an individual, couple, or family collaborates with a consulting professional in gathering, recording, and interpreting data about family relationships. Data are initially drawn from clients' memories as they report and interpret events. These are recorded with standardized symbols that indicate dates, descriptions of events, perceived relationships between family members, and pertinent information about deaths, births, addictions, illnesses, and family secrets known to the client. Details such as names and ages of all family members, dates of birth, marriage, divorce, separation, and death, as well as information about 3 or more generations, are also included. Short genogram symbols. Gender symbols for a genogram. Symbol description: male, female, gender mixed. Symbols for children's links and pregnancy terminations. Symbol description: biological child, adopted child, sign, dash line, foster child. Pregnancy: X on symbol, slash on symbol. Abortion: dying with slash, male stillbirth, male with slash, female stillbirth. Figures 2.1 and 2.2 provide standardized symbols used in genograms to depict gender, children's links, and pregnancy terminations. ASHA 2.111 Major Family Therapy Approaches. In this section, we are going to discuss various family therapy approaches that are commonly used. But before discussing the major family therapy approaches, we would like to see the orientation of these approaches, whether they are based on the client's present life or past life. Table 2.1 depicts the orientation of major family therapy approaches. Table 2.1 Present and past-oriented models of family therapy approaches. Present-oriented, past-oriented. Strategic, psychodynamic. Structural, object relations. Social constructivist. Multi-generational. Cognitive behavioral narrative. Experiential. In Table 2.1, the family therapy approaches that focus on the present-oriented models of family or marital therapy address the current life situation of the family or the here and now, rather than delving deeply into the dynamics or origins of the problem. Conversely, past-oriented family therapy approaches probe into the genesis of the problem, gathering details that are interpreted to provide insights, which are of prime importance in this orientation. Sonnet.1 Psychodynamic Approach. Many pioneering family therapists were originally psychoanalysts who transferred their traditional concepts from treating individuals to treating families. In the psychodynamic model, the therapist's task is primarily to interpret and, through the therapeutic relationship, bring family members' unconscious thoughts, feelings, and experiences into awareness. This includes helping them appreciate the associations between past and present. The fundamental goals of this approach are insight, integration, and adaptive functioning. For example, a family's current behavior may stem from an unresolved and continuing conflict related to a common traumatic experience. When the family represses this aspect of their history, they are helped to see relevant connections. Attention is given both to members as individuals, focusing on their early attachment patterns, and to the family group, examining its typical modes of functioning. Hash 2.11.2 Family Systems Perspective. The family systems perspective was originally developed by von Bertalanffy. Its salient features are as follows. Individuals are best understood through assessing the interactions within the entire family. Symptoms are viewed as expressions of dysfunction within a family. Problematic behaviors serve a purpose for the family. Problematic behaviors are seen as symptomatic patterns handed down across generations, reflecting the family's inability to operate productively. A family is considered an interactional unit, where a change in one member affects all members. This approach is supported by techniques such as family sculpting, where physical sculptures are created to map and explore relationships among members. Similarly, producing a family tree clarifies not only genealogical patterns, but also current relational dynamics. These techniques have the added benefit of incorporating children into therapy beyond verbal communication. The Lev 3 Strategic Therapy. Strategic family therapy was propagated by Watzlawick et al. 1967 and Madanes 1981. For a strategic therapist, two key questions are fundamental. One, how is the symptom helping the family maintain balance or overcome a crisis? Two, how can the symptom be replaced by a more effective solution to the problem? Brief strategic family therapy, BSFT, is based on three basic principles. One, family systems approach. Family members are interdependent, meaning that what affects one family member affects others. Two, patterns of interaction. The behavior of each family member is influenced by sequential patterns of interaction that become habitual over time. Three, intervention planning. Interventions are planned to carefully target and provide practical ways to change those interaction patterns. For example, addressing the ineffective way a mother and grandmother attempt but fail to establish rules and consequences directly related to an adolescent's drug use or other problematic behaviors. BSFT interventions are strategic in that they are practical, problem-focused, and planned. This approach emphasizes establishing a therapeutic relationship, including joining with the family, tracking family interactions, and building a treatment plan. Strategies for producing change in this model include focusing on the present, reframing negativity in the family, shifting interaction patterns through reversals of usual behaviors, changing family boundaries and alliances, detriangulating family members caught in the middle of others' conflicts, opening up closed family systems or subsystems by directing new interactions. HAD 2.11.4 Structural Family Therapy. In this type of therapy, the key work was done by Minuchin, 1974, and Colapinto, 1991. The structural therapist believes that changing behavior is most important. Therapy begins with the therapist joining the family to enhance the feelings of worth among individual family members. The therapist must attune themselves to the family's value systems and existing hierarchies. After joining, the therapist challenges how things are done and begins restructuring the family by offering alternative, more functional ways of behaving. Families are helped to develop communication and social skills. Action techniques, such as enacting conflicts or emotional entanglements, are applied. The therapist is active, and their role is more like a director of a play. Indications. Structural therapy was initially used for children with psychological problems linked to marked social stress, such as immigration, poverty, and environmental problems. Children with behavioral issues and psychosomatic conditions, such as diabetes, asthma, and anorexia nervosa, are also likely to benefit. The aim is to restructure a family whose rigid patterns both trigger and maintain damaging patterns, potentially leading to life-threatening states. SHA 2.111.5 Experiential Therapy. Experiential therapy was developed by Carl Whitaker. This approach applies existential therapy to family systems. The therapist enters the family therapy session intent on having a growth experience for themselves, knowing that this will stimulate the family to do the same. Goals. The main goals of experiential therapy are: 1. Facilitate individual autonomy and a sense of belonging in the family. 2. Help individuals achieve more intimacy by increasing their awareness of their inner potential and opening channels for family interaction. 3. Encourage members to express freely what they are thinking and feeling. 4. Support spontaneity, creativity, playfulness, and the willingness to be crazy. Therapist function. The major roles played by the therapist in experiential therapy include: 1. Creating family turmoil. 2. Coaching the family on how to resolve the turmoil. 3. Serving as a highly involved therapist model, being transparent, taking risks, and engaging with the family during sessions. 4. Helping family members experience the here and now by being with the family. 5. Progressing through 3 phases: engagement, all-powerful; involvement, dominant parent figure or advisor; and disentanglement, more personal, less involved. 6. Using techniques that grow from the therapist's intuitive and spontaneous reactions. 2.11.6 Cognitive Behavioral Therapy for Families. Cognitive behavioral therapy, CBT, for families is brief, solution-focused, and addresses a wide range of psychological problems. Patterns, especially those involving conflict, are examined to identify the roots of problems and set goals for therapy. The focus is on helping family members think and behave more adaptively and make better choices to foster a stable and peaceful family environment. Indications for CBT in the family context: eating disorders and addictions, child or adolescent behavioral disorders, relationship and family problems. CBT in children. CBT for children with anxiety disorders can be particularly effective when the family is included in treatment. Family cognitive behavioral therapy, FCBT, involves a complex interplay of cognitive behavioral techniques and family restructuring, leveraging the combined resources and motivations of children and their parents. While child-focused CBT, CCBT, is effective on its own, FCBT can lead to greater improvements in anxiety, particularly in the short term. FCBT combines cognitive behavioral techniques with targeted family interventions. Phases of CBT for children's anxiety disorders. 1. Skills training. Teaching children techniques for reappraisal of feared situations, relaxation, and self-reward. 2. Application and practice. Creating a hierarchy of feared situations, ordered from least to most distressing. Encouraging children to work through the hierarchy and rewarding them for attempting increasingly fearful activities. Parental influence in CBT. Most FCBT programs have not focused on specific parenting practices that contribute to the development and maintenance of anxiety in children. However, parents who act intrusively can hinder children's independence and exacerbate anxiety by preventing them from confronting benign but feared stimuli. Examples of intrusive behaviors: unnecessary assistance, parents completing tasks that children can do independently, e.g., dressing. Infantilizing behavior, using baby talk or providing excessive physical affection. Invasions of privacy, entering children's rooms without knocking. Parents who allow appropriate levels of autonomy can enhance children's mastery and self-efficacy, helping them regulate anxiety more effectively. The Building Confidence of FCBT program includes individual sessions with the child and complementary parent training sessions. These sessions emphasize the following: giving choices when children are indecisive, rather than making choices for them. Allowing children to struggle and learn by trial and error, rather than taking over tasks for them. Labeling and accepting children's emotional responses, rather than criticizing them. And promoting children's acquisition of novel self-help skills. An incentive system is also taught to parents to encourage their children's courageous behavior. A typical FCBT session begins with a 20-minute individual meeting with the child to conduct skills training or application practice. Skills are reviewed less thoroughly with the child than in child-focused CBT, CCBT, permitting time for parent training, 20 minutes, and conjoint parent-child meetings, 10 minutes. These can be resorted to in cases of children with separation anxiety, but the issues it raises are also applicable to other types of anxiety disorders, such as social phobia and generalized anxiety disorder. CBT in family functioning. The ability of families to resolve conflict and tension depends in part on their communication skills, but also on the ingrained beliefs of family members about individual and family functioning, or what cognitive behavioral therapists refer to as schemas. Schemas, along with emotion and behavior, are a significant part of what constitutes the fabric of the family's functioning. In essence, schemas are used as a template for an individual's life experiences and how she or he processes information. Consistent and compatible with systems theory, the cognitive behavioral approach to families is based on the premise that members of a family simultaneously influence and are influenced by each other's thoughts, emotions, and behaviors. In essence, to know the entire family system is to know the individual parts and the ways in which they interact. As each family member observes her or his own cognitions, behaviors, and emotions regarding family interaction, as well as cues regarding the responses of other family members, these perceptions lead to the formation of assumptions about family dynamics, which then develop into relatively stable schemas or cognitive structures. These cognitions, emotions, and behaviors may elicit responses from some members that constitute much of the moment-to-moment interaction with other family members. This interplay stems from the more stable schemas that serve as the foundation for the family's functioning. When this cycle involves negative content that affects cognitive, emotional, and behavioral responses, The volatility of the family's dynamics tends to escalate, rendering family members vulnerable to a negative spiral of conflict. As the number of family members increases, so does the complexity of the dynamics, adding more fuel and intensity to the escalation process. Parents' family schemas are often disseminated and applied in the rearing of their children. The family schema is subject to change as major events occur during the course of family life, for example, death, divorce, or illness, and they also continue to evolve over the course of ordinary day-to-day experience. Children may also rebuke parents' beliefs and take an opposite stance. For example, I am not going to give in to how she thinks I should act. I will do what I want. A central goal of CBFF is to facilitate as much change as possible, given the influence that schemas have on family dysfunction. Intervention consists of a series of cognitive and behavioral strategies used in restructuring the basic or core beliefs of the family and altering or modifying behavior patterns that are associated with the schema. The behavior component of CBFF focuses on several aspects of family members' actions, including A, excess negative interaction and deficits in pleasing behaviors exchanged by family members, B, expressive and listening skills used in communication, C, problem-solving skills, and D, negotiation and behavior change. The theoretical models underlying behavioral approaches to family therapy are social learning theory, for example, Bandura 1977, and social exchange theory, for example, Tabot and Kelly 1959. In the cognitive behavioral approach, the therapist assists family members in identifying how emotions are commonly linked with specific cognitions and helps family members explore the appropriateness and validity of cognitions associated with negative emotions. Intervening in family schemas. In addressing family schemas from a cognitive behavioral perspective, it is important to follow a series of steps that can facilitate the process of schema analysis and lay the foundation for restructuring. Step 1. Uncover and identify shared family schemas and highlight those areas of conflict and dysfunction that are fueled by the schemas. Step 2. Trace the origin of family schemas and how they have evolved to become an ingrained mechanism in the family process. This is done by probing into the parent's background and the parenting styles their parents used during their upbringing. Step 3. Point out the need for change, indicating how the restructuring of a schema may facilitate more adaptive functioning and harmonious family interaction. At this stage, it is essential to point out to the family that modification of schemas may ease the tension and lower the level of conflict in the family. Step 4. Elicit acknowledgement and encourage cooperation from the family as a whole for a need to change or modify existing dysfunctional schemas. This is imperative for change to actually occur, and it paves the way for a collaborative effort between the therapist and the family members. For family members who have different or incompatible goals for treatment, finding common ground becomes a major objective for the therapist. Using newly gathered information may help in the modification of goals. Step 5. Assess the family's ability to make changes and plan strategies for facilitating them. It is important to determine how capable a family is of making significant changes in their basic beliefs. Potential limiting factors include limited ability levels and resistance to acquiring effective coping skills. Step 6. Implement the change. The family's therapist functions as an instrument to facilitate change, encouraging family members to consider modified versions of their basic beliefs. This is done through the use of collaborative experiences, as referred to in Step 5, brainstorming ideas for modifying beliefs, and weighing the effects that modifications to existing beliefs are likely to have on family interactions. The key in the change process is identifying how family members actually will behave differently toward each other if they are living according to the modified schema. For example, if the family is attempting to adopt a new belief, e.g., it is important to be tactful in expressing negative feelings to other family members, but family members should have the freedom to share such feelings with each other. The therapist helps them identify how they will carry out this belief at the behavior level. Step 7. Enacting new behaviors. This involves trying out the changes and feeling the fit. The use of family exercises and homework assignments is imperative in enacting permanent change. Step 8. Solidifying the changes. This stage involves establishing the change schema and associated family behaviors as a permanent pattern in the family through repeated practice, while family members also remain flexible with regard to future modifications. 2.1.7 Narrative Family Therapy. The followers of the narrative approach consider that experience rooted in life events is elaborated in the form of a story, which gives these events a meaning reflecting the systems of belief. In the therapy process, the life story of a family is connected with the internal and external culture of the family. Change is enabled by retelling the story, in the course of which meanings attributed to the events can change or alternate. 2.11.8 Multi-generational Family Therapy. The therapy was developed by Murray Bowen. The salient features of multi-generational family therapy are as follows. The application of rational thinking to emotionally saturated systems. A well-articulated theory is considered to be essential. It postulates that with the proper knowledge, the individual can change. Change occurs only with other family members. Triangulation, a pattern of interaction where 2 against 1 family member is experienced. A third party is recruited to reduce anxiety and stabilize a couple's relationship. Make the most use of genograms. Differentiation of the self. A psychological separation from others is done. Involves psychological separation of intellect and emotions and independence of the self from others. The greater one's differentiation, the better one's ability to avoid being drawn into dysfunctional patterns with other family members. Multi-generational family therapy attends to the following goals. 1. To change the individuals within the context of the system. 2. To end generation-to-generation transmission of problems by resolving emotional attachments. 3. To lessen anxiety and relieve symptoms. 4. To increase the individual member's level of differentiation. 2.11.9 Object Relations. Object relations constitute a psychodynamic approach to understanding human behavior, development, relationships, psychopathology, and psychotherapy. Many clinicians shy away from object relations because they believe it to be overly complex. Indeed, it is complex in its details, and some of its theorists, like Otto Kernberg, explore these details. However, there is also a straightforward perspective of object relations that is easily comprehended and helpful in understanding relationships. In fact, after clinicians understand object relations, they find that it intuitively reflects certain truths about all human relationships, from the early relationships of infancy, to friendships, to marriage, to the therapeutic relationship. Even students who are new to object relations quickly realize this. The family therapist's purpose is to enhance the feeling of worth of individual family members. Nashtar. 2.11.10 Eclectic Approach. Many practitioners now take an eclectic approach by using various approaches, including cognitive behavioral therapy and psychodynamic therapy, for example. Therapists often work with their clients to create a treatment plan that encompasses different techniques and orientations. 2.112 Basic Techniques in Marital and Family Therapy. Structural, strategic, and transgenerational family therapists at times may seem to be operating alike, using similar interventions with families. Differences might become clear when the therapist explains a certain technique or intervention. Most of the currently practicing family therapists go far beyond the limited number of techniques usually associated with a single theory. There are multiple techniques used in family and marital therapies. These techniques have been derived from various schools of thought and approaches to family therapy. Each therapist follows her or his own approach, depending on the training they have received, experience gained, or whatever they are confident and comfortable with. The following are some techniques that have been used in working with couples and families to stimulate change or gain more information about the family system. Each technique described here should be applied carefully. It cannot be viewed as a cure, but as a method to help mobilize the family. The when, where, and how of each intervention always rests with the therapist's professional judgment, experience, and skills. 2.1 The Genogram. A genogram is a pictorial depiction of a family through 3 or more generations. Often called a family tree, it records relevant and important information about a family. Genograms capture family history by noting relationships, births, losses, connections, patterns, roles, occupations, alignments, communication patterns, health history, and supports. Some genograms also include information on disorders running in the family, such as alcoholism, depression, diseases, alliances, and living situations. Genograms can vary significantly because there is no limitation as to what type of data can be included. The genogram is the basic tool of assessment in family therapy. The therapist starts the session by drawing a genogram while interviewing the significant family members seeking therapy, gaining a rich knowledge of the family history of their clients. By involving a family in the genogram drawing process, they may feel more comfortable talking about certain relationships, losses, or histories. The genogram also opens up a natural means for the therapist or case manager to gather information for the life planning process. Genograms allow a therapist and her or his client to quickly identify and understand various patterns in the client's family history that may have influenced the client's current state of mind. Genograms were first developed and popularized in clinical settings by Monica McGoldrick and Randy Gerson. A genogram is created with simple symbols representing gender, with various lines to illustrate family relationships. Some genogram users also put circles around members who live in the same living spaces. Genograms can be prepared using a complex word processor or a computer drawing program. A genogram helps family therapists make an appropriate assessment of relationship patterns and determine where intervention may be needed to assist the family in reducing their dysfunction or addressing the problematic situation that brought them into therapy. TAD 2.2.2, the family floor plan. The family floor plan technique is used as a diagnostic tool in the early phase of therapy. Coppersmith, 1980. Here, usually, the parents may be asked to draw the family floor plan for their family of origin. The basic premise is to gather significant and relevant information across generations in a non-threatening mode. In the process of drawing a floor plan, points of discussion bring out meaningful issues related to one's past. There is another adaptation to this technique, where family members draw the floor plan for their nuclear family. The importance of space and territory is often inferred as a result of the family floor plan. Other components of assessment include examining the levels of comfort between family members, space accommodations, and rules. Indications of differentiation, operating family triangles, and subsystems often become evident. HAMP 2.3, reframing. Reframing is an important art and skill associated with therapeutic approaches whereby alternative and equally plausible explanations for the symptomatic or complained about behavior are offered to clients. This is done to introduce a difference in communication patterns and open up possibilities for more choices for clients. For example, a teenage father can be blamed for impregnating a girl or praised for his potency. An anorexic girl can be relabeled as stubborn and determined, not sick. A classic example of the opportunities offered by reframing is Langbridge's adage, "Two men look out through the same bars, one sees the mud and one the stars." Similarly, the optimist says of a cup, "It is half full," while the pessimist says, "It is half empty." The ability to reframe or develop new and different acceptable meanings or perspectives for and with clients is what enables therapists to create a context for change and work with clients toward understanding the underlying meaning of their problem. 2.24 Tracking. Most family and marital therapists use tracking at some stage or another. Through this strategy, the counselor learns how the family interacts and then uses this information to establish a therapeutic plan of action. Tracking is a technique in which the counselor respects how the family interacts, but at the same time takes advantage of those family interactions for therapeutic purposes. Structural family therapists, Mnuchin and Fishman, 1981, see tracking as an essential part of the therapist's joining process with the family. During the tracking process, the therapist listens intently to family stories, carefully records events, and notes their sequence. Through tracking, the family therapist identifies the sequence of events operating in a system to maintain its status quo. Understanding what happens between point A and point B or C to create D can be helpful when designing interventions. In tracking, the therapist uses clarification, amplification, and approval of family communication to reinforce individuals and subsystems. 2.1.5 Joining. A number of techniques can be used to establish a therapeutic relationship. Some of these techniques fall into the category of joining or becoming a temporary member of the family. Joining has two aspects. 1. It is the step a counselor takes to prepare the family for change. 2. It occurs when a therapist gains a position of leadership within the family. Counselors use several techniques to prepare the family to accept therapy and to accept the therapist as a leader of change. Engagement or joining begins from the very first contact with the family. Some techniques that the therapist can use to facilitate the family's readiness for therapy include presenting oneself as an ally, appealing to family members with the greatest dominance over the family unit, and attempting to fit in with the family by adopting the family's manner of speaking and behaving. A counselor has joined a family when she or he has been accepted as a special temporary member of the family for the purpose of treatment. Joining occurs when the therapist has gained the family's trust and blended with family members. To prepare the family for change and earn a position of leadership, the counselor must show respect and support for each family member and, in turn, win each one's trust. Specific techniques that can be used to join the family include the following. 1. Maintenance, e.g., supporting the family's structure and entering the system by accepting their rules that regulate behavior. 2. Tracking, e.g., using what the family talks about, content, and how their interactions unfold process to enter the family system. 3. Mimesis, e.g., matching the tempo, mood, and style of family member interactions, preserving the Dana 2.6 Family Sculpting. Family sculpting is a technique developed by David Cantor, Fred and Bunny Dahl, and used extensively by Virginia Peggy Papp, Mauricio Andolfi, and others. In this technique, a physical arrangement of family members is made, either by a family member or by a therapist, symbolically depicting how the sculpt director thinks and feels, relationships are, have been, or how, at a given time, the family sculpt director would like relationships to be in the family. The process of sculpting can be used to show existing relationships, change communication patterns, and/or as an attempt to restructure family relationships. Sculpting is thus a tool enabling family members to comment on past, present, and future relationships, such as how relationships are experienced, what changes family members or therapists would like to achieve, and to get in touch with the psychological distances, feelings, and emotions they arouse. Sculpting is a useful and powerful tool that can be adapted according to the needs of the therapeutic processes. It is beneficial both in therapy and in training therapists. It can be undertaken by the clients only, in collaboration with the therapist, or the therapist may sculpt how they experience the family situation as described by the client. A family member or therapist is invited, or a therapist negotiates permission to sculpt the family to make a living picture of relationships at a time when symptoms emerge, or at a future time when symptoms have disappeared. People are asked to remain silent and notice their feelings as they are arranged in the sculpt. Family members are then invited to comment on what feelings they have about the positions they have been allocated or chosen. When everyone in the sculpt has had the opportunity to express how they feel, the director of the sculpt then invites everyone to move to a position they would prefer and find more comfortable in relation to other family members. The exercise ends with each person being invited to comment on changes they and others would have to make to become and remain more comfortable both physically and emotionally with themselves and in their relationships with other people in the sculpt. 2.12.7 Building communication. Families that communicate well with each other achieve a sense of cohesion and adaptability. Communication is defined as the expression of ideas and feelings assertively but inoffensively, and the reception of ideas expressed by others attentively and accurately. Robin, 1979. Clear and congruent messages, empathy, reflective listening, supportive statements, and effective problem solving characterize positive communication. This enables family members to share their changing needs and preferences as they relate to cohesion and adaptability. Negative communication includes sending incongruent and disqualifying messages, lack of empathy, non-supportive messages, criticism, poor problem-solving skills, and paradoxical or double-binding messages. It minimizes the ability of family members to share feelings, thereby restricting movement on the dimensions. Open communication emphasizes freedom and a free-flowing exchange of information, both factual and emotional, without constraints. Problem communication is characterized by hesitancy to share and negative styles of interaction. Good communication skills are crucial to satisfaction with family relationships. Communication skills training can result in improved family relationships. Faulty communication methods and systems become evident within 1 or 2 family sessions. A number of techniques can be implemented to focus directly on communication skills building between couples or family members. Listening techniques, including restatement of content, reflection of feelings, taking turns, expressing feelings, and non-judgmental brainstorming, are utilized in communication skill building. Some methods include 1. Reflecting. A member expresses their feelings and concerns, then another member reflects back what they heard that person say. 2. Repeating. A member states how they feel, while another member repeats back what was said. 3. Fair fighting. Focuses on attentive listening and expressing feelings and concerns in a non-threatening manner. Repeating and reflecting techniques allow members to better understand why they feel as they do. 2.12.8 Strategic Tasks. Strategic tasks can be broadly categorized into 2 types, depending on whether family members are likely to carry out the therapist's instructions. 1. Directive task. Here is the correct directive tasks. That means asking families to do something that the therapist hopes will alter problematic sequences of interactions, and paradoxical tasks where they are asked to do the opposite of what the therapist intends to happen. 2.129 Restructuring. The following techniques challenge and unbalance the family system, creating movement that forces the family to seek alternative transactions and solutions. 1. While enactment, the therapist has family members perform an interaction that may be relatively innocuous or directly related to the presenting problem. Enactments are utilized to diagnose family structure, increase intensity, and restructure family systems. 2. Reenactment. The family is asked to recreate a situation that has already occurred. These recreations are performed in the therapy session, and the therapist helps to explicate and create a successful outcome to a normally troublesome interactional problem. 3. Actualizing family transactional patterns. By directing the family to have a conversation or by refusing to answer a question, the therapist stimulates naturalistic family interactions so she or he can observe typical transactions. 4. Marking boundaries. The therapist assists the family in setting new boundary rules, renegotiating old rules, or establishing specific functions for each subsystem to strengthen diffuse boundaries or increase the permeability of rigid boundaries, thereby increasing healthy subsystem interaction. Escalating stress. The therapist heightens tension in a family to force the family members to accept restructuring. This is done by encouraging conflict when it occurs, joining alliances against other family members, and blocking dysfunctional transactional patterns that serve to decrease stress for the system. 6. Assigning tasks. The therapist assigns specific tasks for individual family members or subsystems to accomplish in the session or at home. 7. Utilizing symptoms. By encouraging, de-emphasizing, or relabeling a symptom, the therapist alters function the symptom serves in the family system. 8. Paradoxical injunction. The therapist imposes a directive that places the client in a therapeutic double bind, promoting change regardless of the client's compliance with the directive. This technique is typically utilized when resistance to the directive is anticipated. 9. Manipulating mood in the family. The therapist attempts to change the mood or pacing of the family in the session. If the family appears to be lethargic or depressed, the therapist may introduce action techniques to bring more energy into the situation. 10. Support, education, and guidance. The therapist provides direct instruction to teach the family to behave differently. 2.1.10 Circular questioning. The major tool of Milan and post-Milan systemic therapists is the process of asking circular questions. In family systems, each family member's behavior is caused by and causes the other family member's behaviors. They are each impacting the other in a circular manner. Questions are seen as a source of information, suggestion, validation, introducing new perspectives, perturbation, and as an initiator of a search process for patients. Questions relate to the following areas. What is the symptom that the patient presents? What is it there for? What function might it serve? 2. What is the context of the symptom? That is, what is happening when the symptom occurs? Why now? Why this symptom? The physical, psychological, or social reasons for the presence of the symptom. 3. When is the symptom present? When did it start? When is it worse? When better? 4. Who has the symptom problem? Who is around when the symptom happens? 5. Who can make it better? Who makes it worse? 6. Who is affected by the symptom and in what way? 7. How does the symptom affect the family, and how does the family and others affect the symptom? 2.13. Resistance in family therapy. Resistance can be understood in the same way as any other pattern of family interaction. The term resistance refers to the maladaptive interactive patterns that keep families from entering treatment. From a family systems perspective, resistance is nothing more than the family's display of its inability to adapt effectively to the situation at hand and to collaborate with one another to seek help. If the counselor wants the family to be in counseling or psychotherapy, she or he will have to recognize that the client, or a non-cooperative parent figure, is the most powerful person in the family. Once the reason the family is not in treatment is understood, the counselor or psychotherapist can draw upon the concept of tracking to find a way to reach this powerful person and negotiate a treatment contract to which the person will agree. Thus, the key to eliminating resistance to family therapy lies within the family's patterns of interaction. Overcome the resistance in the interactional patterns, and the family will come to counseling or family therapy. Have family therapy, meaning, scope, and applications. Multicultural counseling or psychotherapy literature strongly supports the idea that counselors, psychotherapists need to be aware of their own biases, values, stereotypical beliefs, and assumptions in order to appropriately serve culturally diverse clients. 2.14 Ethical issues in family therapy. Mental health associations have developed standardized codes of ethics to govern the professional application of qualified therapists. These ethics form the basic framework that defines professional therapy and are in no way the same as values. Values differ from ethics in that ethics define the framework of professional therapy, while values predict the motivation and mechanisms of therapy. There are different approaches to ethical issues in counseling and family therapy. They deal with values, principles, and personal moral activities. A brief description of these is given below. The fundamental values of counseling and family therapy include a commitment to respecting human rights and dignity, ensuring the integrity of therapist-client relationships, enhancing the quality of professional knowledge and its application, alleviating personal distress and suffering, fostering a sense of self that is meaningful to the person concerned, increasing personal effectiveness, enhancing the quality of relationships between people, appreciating the variety of human experience and culture, and striving for the fair and adequate provision of counseling and family therapy services irrespective of all considerations. Values inform principles. Values represent an important way of expressing a general ethical commitment that becomes more precisely defined and action-oriented when expressed as a principle. Fidelity, honoring the trust placed in the practitioner. Autonomy, respecting the client's right to be self-governing. Beneficence, a commitment to promoting the client's well-being. Non-maleficence, a commitment to avoiding harm to the client. Justice, providing fair and impartial treatment of all clients and the provision of adequate services. Self-respect, fostering the practitioner's self-knowledge and care for self. Personal moral qualities. Personal qualities to which counselors and family therapists are strongly encouraged to aspire include empathy. Empathy is the ability to communicate understanding of another person's experience from that person's perspective. Warmth. Warmth is also called unconditional positive regard. It involves accepting and caring about the client as a person, regardless of any evaluation of her or his behaviors or thoughts. It is most often communicated through our nonverbal behavior. Congruence. Congruence, or genuineness, is being honest and authentic in our dealings with our clients. The minimum it requires is that the therapist only works with clients for whom she or he can have real empathy, warmth, and respect, rather than role-playing or techniquing those qualities. Sincerity. Sincerity is a personal commitment to consistency between what is professed and what is done. Integrity. Integrity is a commitment to being moral in dealings with others, personal straightforwardness, honesty, and coherence. Resilience. Resilience is the capacity to work with the client's concerns without being personally diminished. Respect. Respect is showing appropriate esteem to others and their understanding of themselves. Humility. Humility is the ability to assess accurately and acknowledge one's own strengths and weaknesses. Competence. Competence is the effective deployment of the skills and knowledge needed to do what is required. Fairness. Fairness is the consistent application of appropriate criteria to inform decisions and actions. Wisdom. Wisdom is the possession of sound judgment that informs practice. Courage. Courage is the capacity to act in spite of known fears, risks, and uncertainty. Other ethical issues. Informed consent in the counseling relationship. Informed consent means clients have the freedom to choose whether to enter into or remain in a counseling relationship, and addresses their need to have adequate information about the counseling process and the counselor. Counselors have an obligation to review in writing and verbally with clients the rights and responsibilities of both the counselor and the client. Informed consent is an ongoing part of the counseling process, and counselors appropriately document discussions of informed consent throughout the counseling relationship. Confidentiality, privileged communication, and privacy. Confidentiality plays a major role in defining the communication between a counselor and a client, bearing in mind that trust is one of the backbones of a therapeutic relationship. Other major issues, such as consultancy with supervisors or colleagues, definition of the type of confidentiality to be used, absolute or relative, prior to the counseling relationship, and session record keeping must be considered by therapists when practicing professional counseling. Complying with ethical guidelines is one of the most important aspects of being professional counselors or therapists. At initiation and throughout the family therapy or counseling process, therapists or counselors inform clients of the limitations of confidentiality and seek to identify foreseeable situations in which confidentiality must be breached. In couples and family counseling, therapists or counselors clearly define who is considered the client and discuss expectations and limitations of confidentiality. Counselors seek agreement and document in writing such agreement among all involved parties, having capacity to give consent concerning each individual's right to confidentiality and any obligation to preserve the confidentiality of information known. 2.15 Counseling Case Studies. The 5 real-life case studies are presented in this section for a better understanding by the students of the problems and situations encountered by the clients and their close relatives, which warrant some intervention through either individual counseling or psychotherapy, family counseling, or family therapy. Names and places in the case studies used have been changed to protect client privacy. Case 1. Relationship difficulties. Ravi and Megha agreed to come to counseling together in order to sort out the differences in their marriage as early as possible. In their own words, they said, "We no longer get on well in anything." There was no longer any communication. They snapped at each other, usually bordering on rudeness and sarcasm. Megha said that Ravi in no way fulfilled her emotional needs, to be loved, appreciated, and cared for. Ravi acknowledged that he was working longer and longer hours in order to avoid going home. He said he was feeling empty and in distress. He said he could not respond to Megha with words of love, as he would feel ingenuine if he did. Both said they felt finished. In counseling, each was asked why they had agreed to come. Ravi said he didn't really want to leave Megha. that he loved her and hoped to restore some of the old feelings of before. Mega was amazed to hear this and also said she didn't want to separate on account of the children who were 6 and 4 years old, as she herself had come from a disturbed home and knew the pain involved of having separated parents. She said she was prepared to stay on in the relationship, even if Ravi didn't fulfill her needs. Assessment. A few sessions were devoted for evaluation, which reflected the dynamics of the underlying problem. It became evident that this couple had a combination of poor communication and past hurts that had not been resolved, and were certainly heading for separation if this matter was not addressed quickly. The counselor suggested to them that if they could improve the communication, and in doing so, unearth and safely talk about some old hurts, there was a chance that they might reconnect emotionally. Work done in counseling. Ventilation. Both Ravi and Mega had the chance to tell their side of the story without interruption, with a focus on the recent past. Mega chose to have one session on her own in order to really get things off her chest. Ravi agreed this was appropriate, and Mega found the chance to ventilate and cry, which was very therapeutic.
Communication.
Counselor taught them a model of communication where one had the opportunity to honestly level with the other about the feelings harbored about a certain issue, past or present. The other had to listen and acknowledge the feelings before continuing with the interaction. Due to the model, feelings could be communicated safely without sarcasm or defensive responses. Past hurts. If not ventilated, past unresolved hurts remain and trigger anger. In and out of session, Ravi and Mega gave each other permission to raise past hurts and talk about them using the communication rules. Outcome. At the commencement of their third session, Ravi and Mega, who were noticeably more relaxed and interacting with affection, said, "Thank you. You have saved our marriage." Ravi said he was feeling lighter. Mega commented that even friends were remarking how connected they seemed to be. Within 3 months of starting counseling, this couple was able to survive the stress of having in-laws from their village staying in the house for 3 weeks, and was thrilled by this achievement together. Case 2. Foreign assignment and relocation to another country and culture. Anjali, early 30s, married, no children, was referred to a counseling center by her doctor because of stress and trouble settling in Paris. She said that she felt unbelievably depressed and had general anxiety that seemed to be bogging her. She and her husband had been in Paris for 6 weeks, their first overseas assignment. Both had moved to Paris willingly and with the usual amount of nervous excitement, perhaps more than usual, as there had only been 2 months' notice that the move was actually happening. Since arriving, Anjali had made good attempts to settle in by joining a support network for women, attending parties with Vivek, her husband, and getting involved in occasional voluntary work. She had left behind a satisfying career as a software engineer and hoped to find work in Paris once she had settled. Assessment. Anjali reported that she knew nobody apart from her husband with whom she could reveal her feelings. At this stage, people were acquaintances, not friends. Her husband seemed not to understand. He was at work all day, building up his work credibility and social contacts. Anjali felt she spent hours alone and yearned for his companionship, yet when she would tell him her feelings, with the hope of having her feelings validated, she found that instead, he would become frustrated with her. This reinforced the guilt she already felt. After all, other women would envy her situation, not having to work, living in an exotic place, no financial worries. So what was wrong with her? Why did she feel so sad? She found that she really missed her work, her financial independence, her day-to-day work routine, friends, and missed Sunday visits at her mom's place, which had been a family tradition for years. With prompting, Anjali could also identify loss at not being able to attend her regular dance class, also loss of the old feelings of being a worthwhile person. The latter had been compounded by the fact that Anjali had sent out many CVs to potential employers in Paris, and to that date had not had a single response. Work done in counseling. The counselor validated Anjali's feelings and labeled the experience she was going through as relocation trauma. This is a situation where, following a move, a person can feel grief at the loss of all the familiar things at home, and experience completely new feelings in a new environment. Due to the fact that many of the emotional and physical responses are unfamiliar, a person can feel out of control or even fearful that her or his life may go out of control and crazy. Through some sessions with Mrs. Anjali, the counselor was able to provide her with a strategy of reframing to enable her to continue functioning in spite of her feelings. Reframing involves looking at the problems being faced from a slightly different perspective in order to consider new options for solving them. This gives rise to hope that different actions will bring about a solution. It provided reassurance that in time, by utilizing the suggested strategy, she would regain a feeling of being in control. The counselor also provided information about resources for social and professional networking. Outcome: Anjali returned for one more counseling session several weeks later. She had been for 4 job interviews in the meantime and had received one job offer. She felt a return of control as she considered the choice of whether to accept the job offer. She was back to her normal self, able to manage the stresses in her life and feeling more settled in the country she wanted to run away from a few months ago. Case 3. Marital problems in the couple, reflected in child's pathology. Mrs. Deepa and Mr. Raju, a couple in their 30s, were referred from a psychiatrist to the marital therapist with complaints of incompatibility between them. They had been married for the last 8 years, and it was an arranged marriage. The husband hailed from an upper-class family. Mr. Raju was the only son of his parents and had a younger sister who was married and settled elsewhere, visiting this family on special occasions and festivals. Deepa's parents-in-law all stayed together. The relationship between the daughter-in-law and parents-in-law was also disturbed. The mother-in-law was described as belligerent and had high expectations of Deepa. This was an issue which caused more problems between the couple. Despite a band of servants at their beck and call, there was always a complaint about the housekeeping and cooking, that due to callousness and bad supervision, it was not attended to properly. Mrs. Deepa was always in tears that despite her efforts to please her mother-in-law, it felt impossible. Assessment: subsequent sessions with the couple and independent sessions revealed that the spouse was a perfectionist and found fault in everything the wife did. He was never appreciative of any of her efforts to meet their expectations. It was evident during the conjoint sessions that he was impatient, a poor listener, and tried to enforce his views on her, much to her displeasure, which she resented. It also became known that his parents had a poor quality of marriage, and to this day, there were many disagreements between them. Mr. Raju, her husband, felt that this should not be repeated in his life, but he could never stop being dominating, and that Ms. Deepa had failed in everything from being an effective homemaker, an obedient daughter-in-law, responsible mother for their son, and a loving partner for him. The couple later also reported that the situation had affected their only son, 6 years old, who had some problems which neither of them could decipher. The grandchild was construed as a normal kid by the grandparents, and Mr. Ravi concurred with his parents' observations. However, the mother, who was a graduate, felt that things were not okay with her kid. On further inquiry, it was found that the child had a history of incessant crying, clumsiness, would drop things, spill while eating, and so on. He was always on the move, restless, and highly distractible with a poor attention span. There were symptoms suggestive of an attention deficit hyperactivity disorder, ADHD. Work done in counseling. Both Raju and Deepa were allowed to narrate their side of the story without interruption, with a focus on the recent past. Deepa chose to have several independent sessions to unburden her heart, as she was quite frustrated, angry, and distressed too. During sessions, she was usually tearful and hence was encouraged to be free and not withhold expressing her emotions. At the end of such sessions, she usually felt better. Ravi agreed this was appropriate, and Megha found the chance to ventilate and cry, which was very therapeutic. Communication. Training in effective communication is an important tenet in family and marital therapy. In this couple, it was observed that each partner was talking at the same time, oblivious to who was listening to them. They were talking at an increased volume, not taking turns, criticizing, and each one blaming the other for what had happened. The couple was educated about healthy communication styles. The need for direct, clear, two-way communication was emphasized, as was the importance of taking turns in an interaction. Criticizing, belittling, bringing up past issues, and blaming were discouraged. The couple was encouraged to look at the positive aspects or the strengths of each other and to give positive strokes or reinforcements to each other. It was noted that as a family, they had no activities together and had recently discontinued the family rituals of eating together, going out, or other celebrations due to ongoing misunderstandings. Mrs. Deepa had also stopped talking to her mother-in-law. These issues were addressed, and the couple agreed to comply with the therapist's suggestions. Outcome: Raju and Deepa gained insight into the circumstances that led to the problem and were determined to bring about the desired changes. However, even after about 12 sessions, there were instances wherein the past issues would come up with disagreements and bitterness, but would calm down within a few minutes. Each had become tolerant towards the other. The problem with the child, which was denied by the husband initially, was accepted, and they became more compliant with the child's follow-ups. Mrs. Deepa, who was working in their own company on a part-time basis and had decided to discontinue due to the misunderstanding, decided to stay on. The husband agreed to return early from work and spend some time with his wife and child. Issues related to the in-laws were also taken up. Case 4. Incompatibility between the couple due to dominant male partner. Mary, 29 years of age, came to the counselor 6 weeks ago with issues of poor self-esteem and lack of self-worth. She has been married for 8 years to Peter. However, in the sessions, she speaks little about him, and when the conversation turns towards him, she quickly tries to change the subject. Although the counselor has noted this shift, she, the counselor, has not challenged her regarding this relationship, as the counselor tries to work on different areas and issues leading up to the relationship. At the appointed time today, Mary shows up with an unannounced Peter for her session. He said he was there because Mary was changing, and he wanted to play a role in what goes on in the session, while getting a notion about what is in Mary's mind at the moment. Throughout the session, Peter dominates and bullies Mary into answers that she would not normally give. At one point, Peter tries to stand over the counselor, who challenges this behavior. Throughout the session, the therapist feels uncomfortable and has feelings of sympathy for the client. At the end of a very strained session, Peter declares that he thinks it would be better if he came to all the sessions so he can see what goes on and what the counselor is trying to fill her head with. In the subsequent sessions, Peter realizes what has been happening to him all these years, and his resentment towards the therapist subsides. He slowly starts opening up and requests independent sessions for himself. In the next few sessions, he discloses the discord in his parents' marriage and the belligerent mother who never cared for the mild and forbearing father who had to suffer at the hands of his mother. Admitting that he didn't want history to repeat itself, he started controlling Mary. He also reported feeling a lot of guilt about the way he had been treating Mary all these years and how depressed she had been suppressing everything. The counselor suggested some activities together for the couple when she realized that there were none between them. Though both Peter and Mary adored kids, they had not discussed having kids, despite being married for 8 years. Outcome: at the end of the 18th session, the couple had resolved most of their problems, had adhered to the homework tasks allotted, had planned for a 3-week holiday abroad, and also had plans for having a child. They requested termination, as it had already been mentioned by the counselor earlier. Case 5. A client with recurrent depressive disorder with inadequate coping skills and interpersonal problems with mother-in-law. Mrs. Shobha is a homemaker in her early 30s, an arts graduate, married for the last 5.5 years to a businessman who owns an electronic shop sales and servicing with a 4-year-old daughter. From the beginning, she stayed with the in-laws. Her adjustment with her husband was satisfactory initially, but it slowly became disturbed due to family circumstances. The mother-in-law stayed in the same family off and on. About 4 to 5 months, she stayed with another daughter in Bangalore. Whenever she was at home, she would nag the patient mainly about her work and child care. She criticized that she did not know how to care for the kid. Whenever the child fell sick, she would not allow the child to be taken to the hospital and would resort to home remedies. She would not allow the child to eat many food items, saying it would cause cold, heat, and so on. The child slowly started refusing food and would throw tantrums for everything that Mrs. Shoba was not able to manage. Mrs. Shoba also had the third episode of depression, and her medication compliance was unsatisfactory. Mrs. Shoba was taken for supportive counseling. In the first few sessions, the patient was encouraged to ventilate, during which she came up with a lot of information about the family and the problems faced by them, as well as the temperament of each family member. The father-in-law was almost bedridden due to a stroke, had recovered to some extent but needed assistance for self-care. The mother-in-law would grudgingly attend to him, and in her absence, Mrs. Shoba helped him. The patient reported that it was not a burden for her, as he was quite cooperative and also a good person, used to be quite supportive towards her, consoling her whenever she felt hurt by her husband's or mother-in-law's comments. She also reported that two of her sisters-in-law, husband's sisters, were mentally ill, suffered from psychosis, and the mother-in-law was disturbed by it. Whenever stressed, she would become angry towards Mrs. Shoba. The patient was also upset because her spouse did not accompany her to the hospital, and there were several instances when he called her crazy mad. However, he took a day off once every 2 months to accompany the sister to the doctor and also bought her all the medications. Though the sister was married, she stayed most of the time in their house doing nothing. However, she was nice towards the patient. Mrs. Shoba would become perturbed on and off due to the prevailing circumstances at home and would seek support from her mother, who was a teacher but would get snubbed by her. The mother, too, had an unsatisfactory married life and could not help the patient whenever she turned to her. Mrs. Shoba had 2 attempts of IS, intentional self-harm, following her problems. Work done in therapy. Mrs. Shoba came for regular sessions and opened up about her problems. Her spouse also joined her for 3 sessions, where he was explained about the nature of the problem she was suffering from and the need for compliance. The problem with the kid and his involvement in child care, at least to some extent, was pointed out. The various problems the family was going through were discussed, and some guidance and suggestions were offered. The spouse, who was also stressed out, was allowed to ventilate, given some suggestions, and reassured. A no suicide contract was taken from the patient, and she has been adhering to it to date. The therapist also gave the contact number to call in case of distress or emergency. In the last 1.5 years, the patient was admitted once for a slight exacerbation of symptoms. She was given some suggestions related to her child's tantrums, and over months, the child has become manageable and takes adequate food. The family also had hardly any routines or rituals and was not spending time together. These issues were also discussed. Outcome: drug compliance improved and follow-up became regular. The child's problems have reduced drastically, able to cope with stress better. The patient is now able to ignore or withstand her mother-in-law's criticisms. The father-in-law died peacefully, and the patient now has not much household work. The patient started going for walks alone or occasionally with the child and involves herself in the child's schoolwork. Goes to church regularly and also reads magazines, watches some programs on TV and enjoys them. Comes in as soon as she develops some symptoms. The husband takes her out for shopping or his office parties, and she enjoys them. To sum up, family therapy as a whole is based on the basic assumption that an individual's problematic behavior grows out of the interactional unit of the family, community, and societal systems. Thus, family therapy focuses on short-term, solution-focused, action-oriented, and here-and-now interaction, with emphasis on how current family relationships contribute to the development and maintenance of symptoms. Specific goals are determined by the family and therapist. The global goal is to reduce the family's distress. The family change involves 1. Cognitive, emotional, or behavioral changes. 2. Change needs to happen in relationships, not just within the individual. The techniques of family therapy are tools for achieving therapeutic goals. Personal characteristics, respect, empathy, sensitivity are even more important, and the therapist always considers what is in the best interest of the family. Resistance in therapy should be identified and addressed in the early phase of therapy. 2.117 Glossary: Blended family, a family formed by the remarriage of a divorced or widowed parent. It includes the new husband and wife plus some or all of their children from previous marriages. Circular causality refers to the fact that in family systems, each family member's behavior is caused by and causes the other family members' behaviors. They are each impacting the other in a circular manner. Closed systems refers to a system with more rigid boundaries that are not easily crossed. Code of ethics, document used in self-regulation specifying the standard of care. Differentiation, the ability to retain one's identity within a family system while maintaining emotional connections with the other members. Emotional cutoff, reduction of anxiety in the system by emotionally cutting off from others. Extended family, a person's family of origin plus grandparents, in-laws, and other relatives. Family life cycle emphasizes how development and change in families follow common patterns which are shaped by the shifting patterns of internal and external demands in any given society. Family systems theory, an approach to treatment that emphasizes the interdependency of family members rather than focusing on individuals in isolation from the family. This theory underlies the most influential forms of contemporary family therapy. Family roles, what is expected of each family member. For example, the basic types of roles are father, mother, aunt, grandmother, etc., daughter, son. Family rules are rules about how the family operates. These rules are often unspoken. For example, are there limits on how much or in what ways kids can argue with their parents? Genogram, a family tree diagram that represents the names, birth order, sex, and relationships of the members of a family. Therapists use genograms to detect recurrent patterns in the family history and to help the members understand their problems. Homeostasis, the tendency of a family system to maintain internal stability and resist change. Multi-generational transmission, movement of emotional processes or themes across generations. Neutrality, the therapist does not side or unbalance, assumes a curious stance, and the team helps him to do so, taking the concerned observer status. Nuclear family, the basic family unit consisting of father, mother, and their biological children. Open systems refers to a system with boundaries that allow a continuous flow of information to and from the outside world. System, a biological analogy, systems theory proposes that various activities of the body are composed of interconnected but distinct systems of components that operate together in an integrated and coordinated way to maintain stability. Triangulation, a process in which two family members lower the tension level between them by drawing in a third member.